Now I'd like to present my friend and colleague, Dr. Amr Abdulrahim, Professor of Vascular Surgery at Cairo University. His talk about cancer-related venous thromboembolism, recent approach.
Assalamu alaikum. I would like to first thank Professor Hashim Sharaf for this nice organization. That's such an elegant conference for vascular surgery. First, about the cancer-associated deep venous thrombosis or venous thromboembolism, we know that venous thromboembolism, including deep venous thrombosis and pulmonary embolism, is an important cause for morbidity and mortality among patients with cancer. The Cochrane Library and the PubMed were searched for randomized controlled trials, and meta-analysis has been shown up and published from the time August 2014 through December 2018, so that the ASCO, the American Society for Clinical Oncology 2019, this year, convened an expert panel to review that evidence and to provide the recommendations to how to deal with this problem. The guideline questions were as follows. First, should hospitalized patients with cancer receive anticoagulation for VT prophylaxis? The second question, should ambulatory patients with cancer receive anticoagulation for prophylaxis of venous thromboembolism during systemic chemotherapy? And the third question, for prophylaxis also, that patients with cancer undergoing surgery should have preoperative prophylaxis for deep venous thrombosis. And then, what is the best method for treatment, and how to the patient with cancer receive anticoagulant in absence of established deep venous thrombosis to improve survival. And the last question, what about the risk prediction and awareness of this problem? The first clinical question, should hospitalized patient with cancer receive anticoagulation for venous thromboembolism? This means that any patient with cancer should receive anticoagulation to prevent the deep venous thrombosis. The recommendations according to ASCO, that hospitalized patient with active malignancy and active medical illness or reduced mobility should have a pharmacological thromboprophylaxis, especially in absence of bleeding tendency or other contraindication. And that was evidence-based with intermediate quality and moderate recommendation. Also, another recommendation that the patient should, routine thromboprophylaxis should not be offered to all patients, just for minor procedures. That means any patient hospitalized just for minor procedures should not be offered thromboprophylaxis. The second question is that any patient, ambulatory patient outside the hospital, should receive anticoagulation for prophylaxis against deep venous thrombosis, especially during systemic therapy. And their recommendation was as follows, that routine thromboprophylaxis shouldn't be offered for all patients with cancer. And this was the high evidence base with intermediate quality, and the strength of recommendation is strong. So, the other recommendation that the ambulatory patient with cancer, and they considered to be a high-risk patient according to Khurana score, 2 or high, this is the patient that should receive thromboprophylaxis and should be taken with, and this patient should take apixaban, rivaroxaban, or low molecular weight heparin, provided there is no significant risk factor for bleeding. And this is the Khurana score recommended by ASCO, and either patient with very high risk primary cancer, those with stomach, pancreas, or brain cancer, high risk primary cancer, lung, lymphoma, and the pre-chemotherapy platelet count at least 350, or hemoglobin level less than 10 gram%, or leukocytic count greater than 11,000, or the body mass index at least 35 The third question, should patient with cancer undergoing surgery receive perioperative VT prophylaxis? That means any patient going surgery and having cancer should have a prophylaxis against deep venous thrombosis. And the recommendation was as follows, that all patients with malignancies are undergoing major surgery should be offered pharmacological thromboprophylaxis, either with unfractionated heparin or low molecular weight heparin, unless there is major risk for bleeding. And this was strong, the recommendation in this entity was strong, and it was evidence-based with high quality. On the other hand, the pharmacological thromboprophylaxis should not be not before surgery only, but should be extended for at least 7 to 10 days after surgery. And the extended prophylaxis can be taken with the patient can take low molecular weight heparin even for 4 weeks more if the patient have a major abdominal or pelvic surgery. So the patient with cancer undergoing surgery, if it is a major surgical, if the patient has major surgical intervention, and so then he should have a pharmacological thromboprophylaxis and should be extended for 17 days and maybe even for 4 weeks if you have a major abdominal pelvic surgery. The fourth clinical question, the patient, what is the best method for treatment of cancer with deep venous thrombosis? Initial anticoagulation can involve low molecular weight heparin, fondaparinux, unfractionated heparin, or rivaroxaban. And it was the evidence-based high quality, and there is strong recommendation for that. For long-term anticoagulation, for at least 6 months, the same, can take low molecular weight heparin, edoxaban, or rivaroxaban. Even the patient can take vitamin K, but it's proven to be inferior to the previous treatment. But special concern for major bleedings with DOACs, especially in GIT or genitourinary malignancy. So that the low molecular weight should be preferred to DOACs in that problem. The third recommendation for treatment, that anticoagulation with low molecular weight or DOACs or vitamin K if the extension of treatment beyond 6 months, the patient need extension of treatment beyond 6 months, can occur if the patient if this patient has a metastatic disease or receiving chemotherapy. So extension beyond 6 months for those having active cancer. The fifth question, the patient with cancer receiving anticoagulant in absence of established thromboembolism. If it's important to take it for improving survival, and the recommendation that anticoagulant is not recommended to improve survival in patients with cancer without venous thromboembolism. And the last question, what about the risk prediction? And there is substantial risk for deep venous thrombosis, especially between the cancer patients. So risk assessment should be conducted based on the special scoring system like Khorana score. And the oncologist should educate patients regarding this deep venous thrombosis, especially in patients with increased risk at a major surgery or hospitalization. So to conclude, hospitalized patients with active malignancy and acute medical illness should be offered pharmacological prophylaxis in absence of major bleeding. And that this pharmacological thromboprophylaxis should not be offered to all outpatient patients with cancer, and should be only given for high-risk patients with no high risk of bleeding. Also, cancer patients undergoing major surgery should be offered pharmacological thromboprophylaxis and should be continued for at least 7 to 10 days. The initial anticoagulation may involve low molecular weight heparin, unfractionated heparin, fondaparinux, or rivaroxaban, and should be extended for at least 6 months. And lastly, anticoagulation is not recommended to improve survival in patients with cancer. Thank you.